Welcome to Insights from the Couch, where real conversations meet real life at midlife.
We're Colette and Laura, two therapists and best friends, walking through the journey right alongside you. Whether you're feeling stuck, restless, or just unsure of what's next, this is a space for honest conversations, messy truths, and meaningful change.
And our Midlife Masterclass is now open. If you're looking to level up, get into action, and make midlife the best season yet, go to insightsfromthecouch.org and join our waitlist. Now let's dive in. Welcome back to Insights from the Couch, everyone. We have a great episode today on OCD and everything you need to know. Not the OCD everyone claims they have when they don't and they just want to clean their room. The real deal. We're going to be unpacking it all. We have Dr. Brady Bradshaw, our friend who's joined us many times and is one of our favorite guests, and Dr. Robyn Cohen, who is a neuropsychologist. Is that the correct way to say it, Robyn?
Yes, that's right.
Okay, great. So can you guys, first of all, welcome. We're so excited to have you. I have a million questions pinging already. Thanks for being here.
Thanks for having us.
And can you just start out by tell us a little bit about you so our audience knows that you guys are, how you guys are dialed into this work?
Yeah, I can go first. I'm a child and adolescent and adult psychiatrist. I'm a physician. I do diagnostic evaluations as well as prescribing medications. I also do psychotherapy, psychodynamic psychotherapy with patients. And I have a private practice in Orlando in Baldwin Park.
Right across the street from me, actually. And we never see each other, which is so bizarre. And we live around the corner from each other and we don't see each other there either. Too busy.
I know.
And Robyn, how about you?
So I am actually a developmental neuropsychologist. So I see children, adolescents, and young adults. Currently, I do evaluations in private practice in Winter Park. But prior to that, I ran the neuropsychology, pediatric neuropsychology department at Arnold Palmer Hospital. And prior to that, I did do treatment actually specific and research specifically with OCD.
Wow.
So let's start off. Just what Colette was talking about, people so flippantly refer to their OCD like, oh my God, I am so OCD. I got to clean my room, or I need things just a certain way. Like, that is not it, right? Can we get like a real working definition of what is OCD?
Basically, when you have clinical levels of obsessive-compulsive disorder, it's comprised of obsessions, which are really severe intrusive thoughts that cause extreme distress. And then the compulsions come in as behaviors that you do to try to relieve the distress of those obsessive thoughts. And that causes significant life impairment in terms of taking hours per day and can interfere with your relationships, with your working. And it's a pretty broad range of severity that you can have. But your urges to kind of get things the way you want them and order them, is not really what we consider a clinical obsessive compulsive disorder.
Yeah. How did that become a thing? That everybody says that. Right? Isn't that what everyone thinks?
I was just going to add, there's that the prevalence is really not very high. So OCD, the prevalence is like 1% to 2% of the population. So it's really not
not as
very common, exactly as it's talked about. ADHD is more common. General anxiety disorders are more common. I think the part that we relate to is the intrusive thoughts, which, Robyn and I were talking about this, are not abnormal. Everyone can have an intrusive thought of, oh my God, what if I crash into this car? Or what if or I need to clean this closet? So we all can have an experience of like an intrusive thought, but it's the intensity and the repetitiveness that it just like keeps staying in the mind and causing a lot of distress. These patients are in a lot of inner turmoil. It's usually very what we call ego dystonic. So it really feels very bad for them to think those things. When we think about like, the colloquial or just like casual use of OCD, it's like, oh, did I turn my curling iron off? Like, let me go check. I'm so OCD. Like that's not OCD. Like we might go and check our curling iron, make sure it's unplugged. And then when we do that behavior, our brain says, okay, done, check, it's not plugged in. But somebody with OCD doesn't have that inhibition. They don't have that stop sign. And so they keep going on that loop over and over. They're not reassured by the checking.
Yeah, I had a client who the intrusive thought was that this person had run someone over. And she couldn't stop thinking that she had run somebody over. And there was not really an incident or anything that had even happened to suggest that. It just was a thought that perpetuated and recycled, and no amount of checking or reassurance actually quelled that thought.
Yeah.
Yeah. To that point, like there are a bunch of subtypes. I mean, I don't think people understand how many different subtypes of OCD there are. But I mean, we're talking what that you're talking about, Colette, is like a harm OCD, like fear of causing harm. But there's contamination. There's like a just symmetry, a just right OCD. Like what falls under the umbrella of all the different clinical subtypes of OCD there are?
There's various ones when you look at kind of like cluster studies and when they in research and subtype it out. Contamination definitely is probably the most prevalent, followed by harm, which usually goes along, the harm obsessions usually go along with checking as a compulsion. There's the symmetry. There seems to be kind of like a pure obsessional subtype where you don't see as much compulsions, but maybe they're more like mental compulsions. So they are compulsions, you just can't see them behaviorally, but they're happening inside their head to neutralize the obsessions. And then hoarding is also related to OCD as well.
Right.
And hoarding can be the OCD type and a non-OCD type, right?
I do think there can be an OCD type and a non-hoarding OCD type. The OCD is that fear of discarding things, and so that's part of the compulsive hoarding. But I think hoarding as a symptom can show up in different disorders.
So, and you mentioned this when it doesn't have a compulsive behavioral component. So I've had clients like that where it's really the repetitive intrusive thoughts. And then they don't do a behavior, but you're saying that can actually, there is a compulsion. It's just mental. So can you give an example of what that might look like?
So I can actually give an example from actually my son who has OCD and he had mental compulsion. So he would get an intrusive thought that something bad was going to happen to me, that I was going to get killed or die. And so he in his head then had to say things in a certain order in his head. Nobody saw him saying this in order to protect me. And it got so significant that, he really wasn't able to pay attention in class or, because this would take up so much of his time before he got treatment for it. So that is kind of just one example of how it can manifest, but there's many ways it could manifest.
Okay.
I had a patient one time that would have an intrusive thought of like throwing her baby off of the balcony of her stairs. And so she would do a mental compulsion of a prayer every time that thought would come into her mind. And again, it's so this is just like Robyn's example with her son or this patient with her baby. It feels so bad because it's so different from what they normally would feel, like she didn't want to harm her baby,
Right.
This was like a very terrible feeling for her. And so the prayer, it's often like prayers or like counting sometimes can be a mental compulsion. And I also wanted to say that there are some people who just have obsessions that don't have mental compulsions too. But
Okay.
I think the numbers, Robyn, correct me if I'm wrong, like 90% of people will have both obsessions and compulsions, either mental or behavioral.
Okay, most people. And
Yeah.
is it true that, because I don't know where I got this and if it's really clinically accurate, but that OCD is sort of on an anxiety continuum, like a more extreme end? Because I have a lot of intrusive thoughts I don't think that I have OCD, and unless maybe I do and I just don't know. But definitely I don't have like the compulsion behavior part, but I will get horrible thoughts about, like, let's say I'm taking a knife out of the drawer. I'll think about how I could like stab myself with it. And I'm like, ugh. I mean, I'm not wanting to stab myself with it. And I think the difference is that thought then goes away. I don't continue to think about the fact that I could stab myself with the knife. But I get a lot of horrific, worst case, how you could die, what could happen. You know, I'm close to an edge. I could hurl myself off. Like my brain will think of that. So is there truth to that that's just like OCD is an extreme form of anxiety? Or what differentiates this from anxiety, if anything, other than the intrusive thought, compulsive behavior aspect?
Right. I mean, and it used to be under the umbrella of anxiety disorders. They've since pulled it out, realizing that there's an OCD type of spectrum and disorders that are more neurologically related to that.
Yeah.
So, but it did used to fall. And anxiety is a huge part. I think that too, when you're experiencing clinical OCD and you get those intrusive thoughts, not only do they feel bad, they cause such extreme anxiety. Whereas when we're going through our day experiencing intrusive thoughts just like that, we all have different frequencies of that experience, but we're not getting that debilitating fear coming with it. Oh my God. And then trying to find some sort of relief to that fear that's associated with it.
Gotcha.
Yeah. Let me tell you guys about the type of client I'm seeing, because I see a lot of anxiety disorders and I see a lot of that intersectionality between ADHD, ASD, all the things, right? And OCD. And so I have like maybe 4 of these types of clients I'll just describe here, who are like really bright women, really creative. Some of them are very high functioning. Most of them have like really struggle with intrusive thinking, a lot of intrusive thoughts. And they talk about it in terms of like their themes are always changing. A lot of it's around good person, like moral scrupulosity, not always because of religious trauma or anything, just because it's like a lot of feelings of guilt. There's also a lot of like fear of they're going to find out they're gay. They're going to find out they're actually transgender. They're going to find out something that is going to make them basically unlovable. And every time, and they want relationships very badly. And when they get into relationships, of course, all of this ramps. And their themes are always dancing around. And they're also very, like, typically a lot of them meet the criteria for ADHD. And many of them will have like a body-based, like picking disorder or like hair pulling. I'm seeing this constant. Am I the only one? Have you had clients like this?
Oh, yeah.
Yeah.
Absolutely.
So
Yeah.
this is related to OCD, what you're describing?
Like, what's the main thing? Is it all of these things kind of dancing together, or is it OCD? I don't know. How do you conceptualize that?
I think there's a high comorbidity with OCD, which I think is one connection I'm making to what you're describing. And so we see a higher rate of, in people who have tic disorder, we see higher rates of OCD. And then like trichotillomania, like pulling hair or like skin picking, those types of things, we see higher comorbidity with OCD. But and then ADHD or autism spectrum, with ADHD, people with ADHD have higher rates of intrusive thoughts as well. So it's like really impulsive. Their brains are going really fast. And then it's like, what's something super scary that could happen right now while I'm pulling the knife out, right? That thrill of that, So there is high comorbidity. And I think the other thing that I was hearing, Laura, and that patient example that you gave is possibly like OCPD as well, which is we would want to differentiate from. OCPD is more of like a personality, what we call a personality disorder or traits, where there's like high perfectionism, guilt feelings, high conscientiousness, detail oriented, afraid of making mistakes. And it tends to be like more pervasive and chronic than, big intense flares of anxiety and OCD symptoms. So the intensity, I think, is different and the clinical picture is different, but OCPD is more like of a chronic, developmentally, you might hear it over years of time, and more of like that intense perfectionism.
Yeah.
Yeah.
Oh, yeah.
I don't know why I just like associate that with more with men. Maybe I'm like just see it in men more. But
Me too.
I don't know. Maybe that's my own
Brady
bias.
and I have talked about that a lot. I mean, I think OCPD is so little known, even among therapists. You touch on it for 2 seconds in the DSM in our pathology class. And I think a lot of times with OCPD, people don't come to therapy unless their relationship is suffering. I see a lot of it in my office because there are maybe one of the partners has OCPD and they can struggle relationally because of the rigidity and all of that. Yeah. So it's
Yes.
and it's confusing because it's obsessive compulsive personality disorder, but it's really nothing like the mood disorder.
The anxiety disorder.
Yeah.
Yeah, it's poorly named, unfortunately,
It
I
is.
think.
Yeah.
I think it's even slightly more prevalent than
It is.
OCD.
Yeah.
OCPD is more prevalent.
That's fascinating.
But I'm not going to see it, like you said, because those people are probably only seeking treatment when they're in a couples or a family type, therapeutic. They're not seeking it for themselves.
Because a lot of those qualities are really great in terms of thriving at work. I know I'm not saying anyone who's a workaholic has OCPD, but I do think that those things can go hand in hand. And unless the partner is saying, this and this is a problem, I think rigidity is always difficult, especially on relationships. So that's where it can interfere. But at work, it's like, this works great, right? I'll just
OCPD is like ego syntonic, right? It's like they think they're great.
proud
Like
of
it's
it.
working for them. Like the people who come in to therapy for like intrusive thinking and like they're disturbed by and what they're really almost shopping for, and like this goes to treatment, which we can talk about in a minute, is almost like reassurance.
Yes.
They're really shopping for reassurance, which is why we can treat this really wrong. If people are improperly trained, this can go poorly.
Yeah. And I've had so many clients in the past when I used to work with a lot of individuals who were just never diagnosed. And it was very clearly OCD and they were misdiagnosed forever. Is that typical that it's hard to get an accurate diagnosis for a lot of these people?
I think so. What do you think, Brady?
I do hear that from my patients. I think there's a lot of reasons that might be the case. One is that people often have a lot of guilt and shame around their symptoms because the intrusive thoughts can be really terrible and ego dystonic. So they might be afraid of being labeled as like a sexual predator or deviant, or like that they're a bad mother if they feel that way. Like there's so much shame around it that they can be sometimes reluctant to disclose even to a professional what they're experiencing. So I do hear that they either are reluctant to disclose or they get like mislabeled for those like intrusive thoughts.
Okay, so before we get into treatment, let's talk about if someone's listening and they're wondering if they have OCD. I mean, obviously we're defining here the intrusive thoughts and the compulsion, the drive to do certain behaviors to reduce the anxiety or relieve the anxiety around those thoughts. What might someone look for and think about if this could be a factor in their life?
Well, I think it depends on time spent. That might be one thing I would look for.
Okay.
So if you're spending a lot of your time going back and checking the door to make sure it's locked, and maybe now you're late for work, like that would be a good sign that this is impairing to the point that it's really becoming a problem. So time, I think, is one thing that I really look for, time, and then intensity or level of distress.
Okay.
So is this something that you're quickly like, oh, did I lock the door? Let me check. Did I lock it? Check again. Okay, I'm good. Or is it like there's hours of going back and checking and thinking about it, and I'm distracted at work because I'm thinking, did I lock my door at home?
Yeah. No, the distraction and the attention, because a lot of times people think, oh, well, I just can't pay attention. It's ADHD, I've got a deficit. But really, it's that they're attending to these intrusive thoughts and monitoring for them sometimes, even. And so
Mm.
it's something important when somebody comes in with attentional issues to definitely look at and roll out.
Mhm. And I think because the fear sometimes is irrational and they're able to identify that, that's another reason that they can be sort of like reluctant to disclose. Like, I've even had physicians with like health obsessions and they know, you know, logically that it's not rational and they will still,
Right.
they know
Right.
it's irrational, but they can't, it feels stronger than their rationality.
Right. And then the conundrum is that the compulsion and the behavior actually perpetuates the whole thing and keeps it going. So, and I want to get into the treatment thing, but can you give us a little explanation of what's happening in the brain with this? Because there really is a difference, right? I mean, I think, and I don't know if this is right, but what I learned a million years ago was it's almost like a gear shift getting stuck. Like you can't quite shift into another gear. And maybe that's not quite accurate, but what's happening for people with this? Because like you said, they know that it's not necessarily, maybe on some level, consciously, I didn't run anybody over. I locked the door, but you still can't help but have that thought and the need to check.
Yeah, I think that's a great metaphor. I mean, it's there's a lock almost that happens in a loop and you can't get out of it. And there's brain structures that look different just on regular neuroimaging. They're on functional neuroimaging. You can
Mm,
see differences functionally in the brains of people suffering from OCD versus normal controls. So, yeah, there's a lot of biological mechanisms that are happening. And then after treatment, the symptoms remit and treatment is successful, when they go back into a brain scan, their brains look like more of the normal controls. You don't see those
That's
brain
fascinating.
activations that you did when they were suffering. So
wow.
it's a really fascinating disorder to study from that kind of neurological pinpoint.
That's
Yeah.
fascinating.
It's funny, like what I've heard, and these clients really do suffer. I mean, it is so agonizing
Yeah.
to be battling thoughts all the time. And my
Exhausting.
clients will say it feels like a flock of birds are attacking me. Like, and they just aren't able to like find the forest for the trees. Like, it's so overwhelming coming in on them.
Yeah.
And yeah, I have such compassion for
Yeah.
what it's like to do. And these thinking structures are so tricky, and it always seems to attack people like on the level of their values. Like the more they care about something, the more the intrusive thinking will attack them. And it's very tricky. So it's always shape shifting. And I just can't say enough about how much compassion I have for how much work it is to live with something like this. And you can't see it. So
Yes.
it's hard for anybody, it's hard for the person to have self compassion because it's like, is this thing real or am I just crazy?
Yeah. Yeah. And I think
Yeah.
it's hard for people to, when I see the partners in therapy, often there's just so much frustration
Yeah.
with it, how it also interferes with the partner's life then, because we were 2 hours late because we had to drive back 25 miles to check the stove again when we had already checked the stove 10 times. A frustration and a difficulty relating to it, because if this is not something your brain's doing to you, I love that flock of birds analogy. If you're not being attacked by a flock of birds, it's hard to know what it feels like to try to move through daily life being attacked by a flock of birds.
Mhm.
So I think it is really important, if somebody has OCD in your life, to understand what's happening so that you can have some compassion for it. And also that partners don't inadvertently collude with the whole mechanism that perpetuates and exacerbates the OCD, right? We don't want everybody enabling it so that it gets worse. So let's talk about because there is hope for this to be better. I've seen it a million times. I know we all have, right? How different it can be. I did not know that it changed how the brain shows up on these scans, which is fascinating to hear.
Yep.
So, all I know of is ERP. My understanding is that's the gold standard, exposure response prevention. Is that so? What works? Do we need meds? Does it just depend on the person? Tell us what's the best practice for treating OCD.
Yeah, ERP is still recognized as a very helpful treatment as part of cognitive behavioral therapy, CBT. So depending on the severity, which most of the people that I see, when they're walking in to see a psychiatrist, the severity is pretty high. It's pretty intense. Right. And so usually it's a combination of medication and therapy. The therapy, CBT with ERP, is hard work for these folks, like exposure response prevention is you're telling me not to do this thing that feels like I have to do it. And and it soothes my terrible anxiety and distress. So it's not easy to tolerate this type of therapy. And so often medication is needed to help. And SSRIs, serotonin antidepressants, are the sort of gold standard medication that we use to treat OCD.
Like a Zoloft.
Zoloft or Prozac. All of the SSRIs have good data for OCD. Clomipramine, which is a tricyclic antidepressant, also has good data for OCD. But because of side effect profiles, we usually go with SSRIs first. And patients with OCD tend to need higher than the upper limit of the normal doses of those medicines. So Prozac for somebody with depression or anxiety, we might do 20 or 40. But I've had patients with OCD on 100 milligrams of Prozac. So you sometimes really have to crank the dose up on the medication. But I really want those patients also to be in therapy and you really need both.
Right. That makes sense. Yeah. And in fact, Brady, I think we have shared patients where I did not know. One of the common things I see is that people are getting psychotropic meds from their family practitioner or internist. And let's say OCD is happening. They're getting like a low dose of Zoloft and saying, oh, well, it didn't work for me. Right. And I had no idea until I think I had sent somebody to you, Brady, that was even a thing that was done or why that was needed and that can be effective. So if this is a factor for somebody listening, in my opinion, at least, is that it really is worth it to see a psychiatrist.
Mm-hmm. Yeah. And a therapist who knows how to do CBT with ERP. I don't know, Robyn, if you want to speak more to that, but Laura, you sort of alluded to supportive therapy that's just colluding with the OCD is sometimes more hurtful than helpful. So
100%.
Yeah. And it's not easy. It's not easy. It's not an easy therapy to deliver. It's not an easy therapy to receive. It's not, not everyone responds to it, but it does have good effectiveness for a good portion of patients that are especially motivated patients. Speaking from someone who's done it with children and adolescents, it's really important to get family to be educated in how to support at home, because doing the sessions really won't help that much without the carryover into their day-to-day environment. And also too, your sessions have to be very flexible because it's not something that can neatly fit into like a 45-minute session. If you're doing this therapy, you need to have the flexibility. Some therapy sessions might need to be a couple of hours, because ending a session in the middle of doing an exposure when that anxiety has not decreased could cause more harm than benefit. So it can be very life-changing and effective, but it really needs to be with somebody who has a lot of experience in delivering that type of therapy.
You are so right, because there are so many therapists who have absolutely no idea about any of this stuff. There's so many things to focus on and specialize in that if this is not something you've drilled down on, you just might not even know what would help. So can you guys just give a little explanation? Because we're talking about ERP and CBT, and we said the full names: exposure, response prevention, cognitive behavioral therapy, but our listeners mostly don't know what those things are. So can we just give a little definition of that kind of therapy?
Mm-hmm.
Sure, absolutely. So the exposure part of exposure and response prevention is eliciting the obsession or the intrusive thought that's causing distress. So you elicit that in the session, and then that creates an urge to do the compulsion to neutralize that obsession. And so the therapy is basically stopping, the compulsion, having that anxiety of that obsession, just keep going and keep going, because eventually it has to decrease on its own without the compulsion. You cannot stay in a physiologically aroused, anxious state when there is no direct threat to you for an extended period of time. And some people could experience that decrease in anxiety in a few minutes, but some might take hours, but eventually you just literally cannot physiologically sustain that. And every time that anxiety goes down without the compulsion is like a step in the right direction.
New learning.
Yeah,
Yeah.
exactly.
We're
Exactly.
rewiring. Mm-hmm.
Exactly.
Rewiring and learning that you don't need the compulsion in order to reduce your anxiety, that you can actually ride the wave of the feeling, get to the other side without doing the thing. And that's what starts to help your brain change and know that you don't need those behaviors.
Exactly.
And Robyn, I think this is true, but it's usually done in a gradual way so that you're not flooding the patient's system. So it's not like if they have a contamination fear, you're having them eat food out of the trash. Like it's not that fast.
Right. But you do
Um,
eventually have to get to that point. So you
right.
make a hierarchy of what would be the least fearful thing and then what would be the most fearful thing. But when you're doing the protocol, you really need to get almost like above and beyond. So like I've had kids that had to like touch toilet seats in public bathrooms and touch their face, contamination, like taking a French fry and like putting it on the McDonald's table and then eating it. So, you do things that even we would not do normally, but you do need to take it that far to help like with remission. It just seems to be the most effective when you go to that extreme with it. But you would never do that until you've already had so much success with so many other things.
Right.
Yeah.
So, yeah.
I also like ACT therapy, which is acceptance and commitment, especially with my clients that have a lot of like thinking, intrusive thought based OCD. It's really the tolerance of uncertainty, right? Like, and the fact that we can't know for certain if the relationship they're in is ever going to work out. We don't know for certain if they'll fall in love with a member of the same sex, and like beginning to tolerate uncertainty and to build the life worth living anyway. Like we're always toggling back between like the life worth living, because that builds the willingness to do the work.
Right.
And I love that model, the ACT model, which is a behavioral based model as well, for helping OCD clients, especially my intrusive thinking based ones. I think the exposure for contamination and just right and all that stuff has to be there. And sometimes exposure for these thinking things has to happen too in a structured way. But I notice how shape-shifty it is, that as soon as, you season one, they just come up with a new theme.
Yes.
And underlying it all is just like that you can never be certain about life on any level. Mm-hmm. And can you tolerate that?
Mm-hmm. I think the fears, this may not always be true, but a lot of the patients I see with OCD, the fears that they have are so fantastically bad that to accept it would be intolerable, like throwing your baby or running over a person, I think that speaks to the intensity of OCD. And then maybe that's why it got separated out of the anxiety disorders, because it starts to kind of even cross into like magical thinking, or like it gets almost
psychosis.
bizarre in the fear.
Right.
And they know that. That's why it's not psychotic. They know it's not real.
Yeah.
But it is really stressing.
Yeah. Yeah. And that was what I found fascinating about that ERP training, was the hierarchy part of, Laura, we remember that with Laura Myers, where she talked about like the scale of 100 and starting with targets that are, say, like I had a client who's afraid to drive over bridges. So you don't start with, I don't know what's the scariest bridge or anything out there, but like a really high bridge that has no guardrail and you're on the edge. You might go over a bridge that's low where you can stay in the center. And even that was intolerable to this client. But it is amazing how just without OCD, exposure to things that scare you is the thing that builds confidence, that changes it. So it makes sense that this would work, but also why it's so difficult. Somebody's really got to be willing to do the thing and do the thing repeatedly. And it's very hard to do something that you feel afraid of. It feels counterintuitive, or to not do something that brings you relief. But what seems to be what you guys are suggesting, and what I've seen in my limited therapeutic experience with this, is that this is something that really can change. There's a lot of hope. There's a lot of freedom from this, right?
Absolutely.
Yeah. Oh, yeah. Absolutely. And the going from living in such distress to the freedom that, and it's ironic, right? Because there's a lot of control with OCD, or trying to control a lot. But when you let go and you do this treatment, or you take medicine, then the relief on the other end is so life-changing. Yes. And I'm sure, all disorders, obviously, when there's treatment and there's relief, there's a big difference in life change. But for some reason, OCD really sticks out as something that you really can just completely change the trajectory of your life with that treatment.
Yeah, which is amazing.
Another thing I just wanted to mention, because I do think it's really helpful and hopeful, and Robyn, you and I have talked about this before, and I think this is part of a CBT technique, which is to name the OCD as something apart from the person.
Mm-hmm. Yes.
I feel like that is specifically helpful for OCD patients, because I don't know, that it just like creates some space. Maybe there's some release of control there. And I think it normalizes and maybe reduces some of the shame and guilt that they feel. So I don't want to throw my baby. My OCD is tricking my brain and making me think that, but I don't want to do that. It's not mine. It's my OCD.
Yes.
And then at the end, you go from this perspective change of that was controlling me, and now I'm controlling that.
Yes.
That's not separate.
Yes. You're leading your OCD part. Yeah. Yeah. And, it's like what Brady was saying about how scary some of these things are. They are really scary. And I think it speaks to that when you have to have a really well-trained therapist. You have to have a lot of trust with your therapist. And the therapist has to be like really, and very often, very creative. You're coming up with like interventions that are very offbeat often. Like I was listening to a guy who had this fear that he was going to kill himself, but he was like, it was an ego dystonic fear. He did not really want to kill himself. He just thought he was going to take a knife and kill himself. And literally the treatment was he had to sit for like an hour a day with a knife to his throat. Like he built up a certain amount of time. But can you imagine as a therapist, how much trust you'd have to have in your therapist to begin to sit with like a knife to your throat? Eventually, the upshot of this is he eventually got bored. He was just like, okay, I guess I don't want to kill me. Like he wasn't afraid of it anymore. But like these irreverent treatments that are scary.
And as a prior therapist who did this work, we were always in constant consultation with other therapists who also do this work because when you get creative, you want to bounce these ideas off other people and, oh yeah, no, I've done that before, or no, this is this could go wrong with that. So it is very important from the therapist's perspective to always have somebody that's also doing the work to be able to work through any new situations that are going to come your way.
Mm-hmm.
Okay, so I want to ask too about relationship OCD, right? Is this a real thing? Like, what is it really? Because I had a client come in and say, like, I am diagnosed with relationship OCD, and I had to really like look it up and do a deep dive into it. And I'm still not sure how clinically accurate this is. So where do you guys fall along those lines?
I have not heard of that. I'm
Okay.
interpreting it as an anxious attachment, maybe, like an attachment. I would probably use that lens. It's not a DSM diagnosis.
Right.
I have a client who would cop to that. And what she describes is something where it's like she'll get into a relationship and very quickly she's looking for evidence that she shouldn't be with this person. And that she's like, am I attracted to him? Do I still like him? Should I break up with him? Are we compatible? If we're not compatible in this, and it just keeps proliferating.
Yeah, that was similar to the guy that I saw.
Yeah.
But it sounds like it's one of those internet diagnoses,
Well, or it could be a significant OCD in that person, and that's just the form that their intrusive thoughts are taking. So almost maybe like a subtype, but not its own distinct diagnosis.
Yeah.
Right. I guess I wondered if it was a real subtype, but maybe anything can be. I mean, you could be preoccupied with anything.
Yeah, I would think that would fall under a subtype of like a checking kind of thing.
Okay.
Yeah.
What about health anxiety? Like, can health anxiety have an OCD component? Is that under the same OCD umbrella? I mean, I know like it can be like in its own category, but I feel like OCD and health anxiety can dance quite a bit.
Yeah, I think that would go under the subtype of like a fear of harm, so they like are really afraid that something's wrong with them or that there could be something harming them. And so that leads to the compulsive checking and like either checking your body or like multiple doctor's appointments. I've definitely seen a health anxiety OCD, that for sure.
Yeah, or I'll have people who are constantly looking things up every day. They're sure they have something new every day.
Mm-hmm. And now we have like ChatGPT to really fuel that, which is like, it's very concerning because you can talk to ChatGPT all day long.
Yes.
And it will reassure you endlessly.
Right. Well, and you've seen the stuff about how ChatGPT has also helped people take their own life.
I know. This is terrifying.
Yeah. Technology creates new problems.
It sure does.
How do we support people? If you're in a relationship, somebody listening is in a relationship with somebody who is suffering with OCD, or you're a parent and you suspect your child is dealing with OCD symptoms, like how is the best way to support, besides like medical intervention and getting a psychiatrist on board and treatment, just parenting or loving or supporting a person with OCD? What are some of the best practices?
Well, I mean, obviously getting the professional support is number one, and then that professional will be able to support the caretaker in terms of, giving specific kind of strategies for that specific situation. But in general, keeping a framework of this is not who this person is. This is a disease that this person is suffering from, and trying to find the best way to straddle being supportive without constantly giving in to, like you said earlier, going back 25 miles to check the stove, even though you've already checked it, being able to be comfortable with, we're not doing that. I'm thinking from a parent perspective, obviously, because that's what I primarily deal with. But I don't know, Brady, do you have any adult kind of examples?
Yeah, I mean, it does take a lot of compassion, I think, if we're thinking about a partner example, because sometimes your partner might be doing behaviors that you can see are really the OCD and not your partner. Like you're saying, Robyn, it feels like it's different from who that person is. And so sometimes I think it can be hard to be patient with that because it does consume hours that maybe then they're not available to the partner, to the other partner. But to be compassionate and know that it's not as simple as saying like, we can't vacuum for 2 hours tonight. Like we're not going to, like you can suggest and encourage and support, but they may not feel like they can help themselves. And that's why you do have to often have a medical piece involved where they're getting therapy, they're getting medication to support that, because the partner telling the person not to do the behavior, that's not really always very effective or compassionate. You can encourage like, hey, do we need to drive back? Like maybe this is your OCD, like maybe we could just keep going. But they may not be able to. And so being able to accept that and that they are in a lot of distress, I think is important. I can also just make a comment about the family thing. Is that okay? Can I?
Yes, please.
Have time? I think for a family, if a child is suffering or a teen with OCD, for the parents and the family to be thoughtful about initiating therapy also and making sure that it is a good fit before starting ERP, because I have seen where the parents can't tolerate the hierarchy of exposure and will swoop in and pull the child. And that is really reinforcing the OCD. So try to be thoughtful at the beginning so that you're not committing to something that you're going to have to swoop in and pull out, and make sure that as a parent, you can tolerate the plan before you start it.
When I was treating children and adolescents, maybe older adolescents, I would do some sessions individually, but I always included the parent, because without the buy-in from the parent and the motivation from the parent, it's just not going to work. And it's just as important for them to learn this as it is for the child to learn it too. So, I would say it's a pretty big red flag if you have somebody that's just like, oh, I'm just going to work with your kid and this is what we're going to do. And I'll see you when we're done with our session.
That's such good advice.
Good point. Yeah.
Yeah. So, okay, really, like a takeaway here that we're all saying is this can be so hard to suffer with, and there can be so much shame attached. And when it's happening to you, it's so overwhelming, and it probably feels like you're the only one. You're not, but really take the step to get help, because help is so possible. It's out there. Find a good doctor and a good therapist who have worked with patients and clients that have OCD, so you're going to get the right treatment. And it's amazing how different it can be on the other side. There is freedom from this. So it's exciting to have something that actually can change and be helped when, some of the stuff we're challenged with seems so fixed and immovable. So as we wrap up here, can you guys let our listeners know how they can find you?
Yeah, we're both in Orlando. And my website is baldwinparkmed.com.
And I'm in the Winter Park area, and my website is theneuroco.com.
Wonderful. Wonderful. And if you guys are not in this area or in Florida, Google and look in Psychology Today, ask around if you have a therapist, really find somebody who knows what they're doing with this, because it's its own thing. And you want somebody who has additional training for this specific thing.
Absolutely.
Yeah. Thank you so much for being here. Really, I learned a lot, and I know our listeners will have too. And to all of you listening, thanks so much for tuning into another episode of Insights from the Couch. We hope you got some insights from our couch today, and we'll see you next week.